right, so this is the first time that I will actually be doing this presentation. This is a brand new presentation I've been working on, so I've been up to my ears in research around core stabilization, around the transverse abdominis and all that sort of stuff. So it's a very, very research-heavy presentation because I wanted to give the audience lots of material to go home and read. So we're going to talk about all of the history of where the core stabilization idea kind of came from. We're going to talk about the transverse abdominis and muscle firing and onset firing times of muscles and all that sort of stuff. And then we're going to kind of move into looking at different modes of exercise and comparing them to each other with, with the thought of, is one better than the other? And then we're going to kind of finish up talking about some of the best evidence-based recommendations for the management of low back pain. So these are the objectives. Learners are going to gain a history and understanding about the core stability hypothesis, all the stuff that I just talked about. So where did the core stability craze actually come from? So as best as I can tell from talking to many people and reading quite a lot of the research, it for the most part originated in the early 90s with some research that Paul Hodges was doing. This is kind of a landmark study that really got the whole core stabilization buzz going. I'm gonna let somebody into the, oh no, that's a chat. And it opened the floodgates for a ton of other research to be done and a lot of buzz to go around with theories about how we should approach the treatment of low back pain. So this was probably the most crucial 50 milliseconds that ever occurred in physical therapy history or in rehab low back pain type history. So what Paul Hodges did in this study in 1996 was they implanted fine wire EMG into people's rectus abdominis, multifidus, transverse abdominis, all of the different muscles in and around the core. And the group of patients that they had was 15 patients with an average history of 8 years of chronic low back pain and 15 age-matched healthy controls. And what they did was they had patients raise their arm as quickly as they could after a light, and they measured the onset timing or the latency of onset with the transverse abdominis, the rectus abdominis, all the different muscle activity. And when they looked at their data, what they found was that it seems like those people with low back pain had a delayed onset of the transverse abdominis muscle when they would quickly raise their arms to the front or out to the side. The interesting thing about this study design was that they only looked at the contralateral side. So if the participants were raising their right arm, they did all of the EMG measurements on the left side trunk muscles. And they found on average, if you can see those arrows, about a 50 millisecond delay in the onset of the transverse abdominis muscles. And they found that in the healthy controls, the transverse abdominis muscle actually activated prior to the movement as kind of an anticipatory bracing type maneuver. And in those people with back pain, that was delayed until after the movement actually occurred. So after the onset of the shoulder flexion or the shoulder abduction is when the transverse abdominis began its contraction. So we saw some sort of delay or some sort of alteration in the way that the muscles were functioning in those people that had a history of 8 years of chronic low back pain. So if we look back on this retrospectively and knowing what we know now, we know that chronic low back pain is a really complex condition. It causes a lot of motor changes. It has psychological factors that go along with it, sociological factors that go along with it. So to try to break it down into a single factor such as a specific muscle's onset was probably a little bit overreaching. And I don't think that Paul Hodges in his group actually said that, but I think those of us in the crowd reading his research came away with that conclusion and took it and ran with it way faster than we probably should have. So should we blindly trust this data? We look at this data, it had a pretty wide confidence interval. There was a really big standard deviation. And if you look back, you can actually see that in the low back pain group with shoulder flexion, there's a 104-second standard deviation plus or minus, or a confidence interval on the onset. And in the non-low back pain group, yeah, it occurred before the shoulder flexion, but there was also quite a bit of variance to even going right up to the point of them occurring at the same time. So we see this really drastic difference between people in the way that they've adapted to their pain. And one of the things that they don't talk about in the research findings, and they said was non-significant, I found really interesting when you look at the data, is that the speed with which people raised their arms was 300 degrees per second in the healthy controls and about 230 degrees per second in those people with chronic low back pain. So yes, the onset of the transverse abdominis muscle was delayed, but the speed of movement was actually significantly slower. So if you think about 70 degrees per second was the average difference between those people that were healthy and those people that had low back pain, I would say that's a pretty significant difference in speed as well. So they might not have been moving their arm as fast. They might have been a little bit guarded. They might have been a little bit hesitant to move their arm for fear of their muscles hurting. They might have had some bracing going on and that sort of thing that altered the results. So this is where the core stabilization craze was born. This is kind of where it came from. And there were some follow-up studies that Hodges did with a group of people that had a spondylolisthesis, in which he did some core stabilization exercises, and it seemed like they got a whole lot better. But if you hear him talk about it, he did a follow-up study to that same exact study with the people with spondylolistheses and found that he actually made them worse. And it had the old desk drawer effect. He took that study and he didn't know what to do with the results. I believe you can hear him talk about it on one of the Pain Reframed podcasts, where he took that study and just kind of filed it away in his desk drawer because he was so confused by the results. I'm sorry, that was Peter O'Sullivan, not Paul Hodges. Peter O'Sullivan did a study to follow up on some of this stuff that he was seeing with Paul Hodges' work, because Peter O'Sullivan was originally a core stability guy as well. He was very much in that camp and believed in the core stability idea, yet he did some research that went against his biases, and he didn't really publish it because it confused him and he was unsure of where to go with it. So should we be targeting specific muscle groups, or does specificity matter with our exercise intervention or with the specific way in which we're going about trying to target certain muscles? So if we start to look at the literature, and we're going to start and go chronologically, in 2008, Gary Allison did a study about feed-forward responses of the transverse abdominis, and he found out that they're directionally specific and they're asymmetrical, and talked about what implications that might have for core stability. So Gary Allison in this study kind of set up the same type of deal that Paul Hodges had in the previous study that we looked at, but he looked bilaterally and found out that when you raise your arm, it's the opposite side that contracts anticipatorily or prior to the movement, and the ipsilateral side actually of the transverse abdominis activates at a later time. So you see a difference in the muscle onset timing side to side in these muscles, which completely flew in the face of the idea that the transverse abdominis contracted both sides together to create increased core stability and actually pull through the fascia, the lumbar fascia, and tighten down and cause increased stability of the lumbar spine. So when we're doing everyday activities, we're not seeing these muscles activate in unison with each other. They actually have a directionally specific way in which they activate. So to quote Gary Allison, said that the symmetry of the transverse abdominis, there we go. You guys' faces are all over my screen, so I can't really see what I have written. So the symmetry of the transverse abdominis activity during arm raising suggests that the interpretation of the role of transverse abdominis as a bilateral stabilizer during anticipatory postural adjustments probably needs to be revised. And he went on to say that such patterns of altered muscle activation may be inappropriately maintained in chronic low back pain and at high stress situations, resulting in limited variability of movement patterns. So I think that this is really huge. If you have situations in which your muscles are not firing in their normal way, or they have a delayed onset, or they're constantly kind of contracting, you might have limited variability in your movement patterns. Then if we move on to 2012, we see that Vasseljen did a really similar study. He looked at the effect of core stability exercises on feed-forward activation of the deep transverse abdominis muscles. So this is taking it a step further and not just looking at those people with and without back pain and how their muscles function, but taking those people, looking at how their muscles function, and then adding core stability exercises on top of that to see if we can affect the outcomes. So he put his patients through 8 weeks of core stability exercises, and all of the patients got better. They had a significant improvement in pain, yet they had no change, or no significant change, or no uniform change in the onset of their transverse abdominis muscles. So we see that regardless of the changes in the activity in the muscles or the onset firing patterns, we actually saw a significant reduction in pain. So this kind of flies in the face of the idea that those muscles are dysfunctional, and that dysfunction is causing a significant issue or causing their pain, and that we need to address the firing activity of those muscles, or their onset mechanism, to actually increase their pain. The only difference with this study was that Vasseljen used diagnostic ultrasound to look at the onset of the muscles versus fine wire EMG. So that could alter the results just a little bit, but there's pretty good reliability with measuring the onset of muscles with the diagnostic ultrasound as compared to fine wire EMG. Then if you'll move forward again in 2012, we'll see Gary Allison again doing another follow-up study, which is just the same as Vasseljen's on the previous page, where we saw absolutely no change in abdominal muscle onset with 8 weeks of core stability exercise, yet we saw a pretty significant improvement in pain. So we're seeing exercise work, and we're seeing core-focused exercise work for people, reduce their pain, reduce their disability, yet we're not seeing any change in the onset of those muscles or the firing patterns of those muscles. Then going ahead to staying in 2012, we look at Ann Mannion, and she looked at spine stabilization exercises in the treatment of chronic low back pain. Again, a good clinical outcome is not associated with improved muscle function. So you see 3 researchers in 3 different areas of the world in the same year, 2012, putting out studies to look at the activation, onset timing, and the way in which these muscles around the trunk and core function, and seeing no changes in these muscles, or no pattern at all between the way that they change or don't change with core-focused exercises, yet people getting better. So you can see that Mannion's conclusion was neither baseline lateral abdominal muscle function nor its improvement after a program of stabilization exercises was a statistical predictor of a good clinical outcome. So it's difficult to attribute the therapeutic results to any specific effects of the exercises on these trunk muscles. So they must be working via some other mechanism, is kind of what we're seeing the trend to be. So fast forward to 2014, and do changes in the transverse abdominis and multifidi. Uh-oh, Marcos has entered the waiting room. Okay, sorry about that, guys. So do changes in transverse abdominis and lumbar multifidi during conservative treatment explain changes in the clinical outcomes related to nonspecific low back pain. Now we've moved on. We have a systematic review showing us the exact same thing as the previous studies have shown us. So they're compiling all this data, and they're saying that there's no changes in the onset, activation, or the morphometry, so the actual thickness of these muscles when measured with diagnostic ultrasound, and the relationship between the outcomes in their treatment. So you can get out of pain, you can have less disability, yet there's no difference in the way that the muscles look, the way that the muscles are structured, the way that the muscles function. Okay, so now if we move on to comparing different types of exercise, so is motor control better, or is general exercise better, or is core stabilization type exercises better? And we look at the literature. There's a researcher out of India, I believe, last name Shamsi. I've found some of his research recently. There's really, really well conducted, interesting research that I've never been introduced to before until I set out to kind of educate myself on this presentation. He found that, I'm sorry guys, this is giving me some weird messages here. Okay. So he was comparing core stability and traditional trunk exercises on chronic low back pain using 3 functional lumbopelvic stability tests. So what he did was use a step down test, a runner's stance test, and a forward bend test. And they used independent assessors to measure the stability of the spine. So how much they assessed the movement in the lumbopelvic area during these step down and stability type movements. And what they found was that comparing traditional trunk exercises, which were a lot of curl ups and back extensions, to core stability exercises, which were transverse abdominis hollowing type exercises and dead bug type exercises while holding a transverse abdominis hollowing, there was no significant difference seen between the group in all of the lumbopelvic stability. So these stability focused exercises didn't really change stability better than just general old trunk focused exercises. Then if you move forward to 2016 with Shamsi again, you see, does core stability exercise improve lumbopelvic stability through endurance test? So instead of looking at stability tests like the step down and the runner stance test, he was looking at the side plank test for endurance, the curl up test for endurance, and the back extension test for endurance. And he compared the same type of core stability exercises with general exercise, and again found no difference in the improvements between lumbar extensor endurance, side plank type endurance, and rectus abdominis or curl up type endurance between all of these different between these 2 exercise interventions. And again, he saw that disability and pain was also the same between groups. So regardless of exercise, it seemed like both groups got better, not only in pain and disability, but also in their function on core stability endurance types exercises. Then 2014, one of the most impactful systematic reviews that's been done and really critically talked about in the last 5 years or so was Ben Smith's systematic review on core stability exercises as a whole. And what they found is that there is no strong evidence that core stabilization exercises are more effective than any other form of exercise in the long term, and that there are low levels of heterogeneity and large numbers of high methodological quality studies that are available, and that further research is very unlikely to change their conclusions. So lots of really good research has been done, lots of well-conducted randomized control trials, lots of head-to-head studies where they're comparing core stabilization exercises to other exercise, yet they find no significant differences. And the researchers go so far as to say that it is very unlikely that future evidence will overturn this idea, because this was already an update on a previous systematic review from 2008, I believe, that came away with the same conclusion. So add 6 more years of research, no change to their conclusions. So what about motor control specific exercises? You see Shamsi again in 2017 measured the outcomes of general exercises versus motor control exercises. So the general exercises, again, were things like squats, curl-ups, back extensions, and that sort of thing, whereas motor control exercises were focused on maintaining lumbopelvic stability, maintaining a drawing in maneuver while going through bird dogs, while going through dead bugs, and all those sort of traditional motor control type exercises that we think about. And what they saw was that there was no significant differences between the groups for pain, disability, or stability index between the groups. So they used the same stability indexes that they had used in some of their previous studies to look at whether stability improved or core endurance improved. And then we go ahead to 2016 and we see a Cochrane review that shows that evidence of very low to moderate quality indicates that motor control exercises showed no benefit over spinal manipulation or other forms of exercise or medical treatment in decreasing pain and disability among patients with acute and subacute back pain. So this is kind of it could be somewhat disheartening to look at the evidence and say, well, motor control isn't better than core stability, and core stability isn't better than spinal manipulation, and spinal manipulation isn't better than Pilates, and Pilates isn't better than medical treatment. Everything seems about the same. Maybe nothing that we're doing with back pain is helping, or maybe we possibly have a really, really wide range of interventions that we could possibly use for the specific patient in front of us. So it depends on what lens you want to look at this through. Is it the lens of nothing seems to work very well at all, or everything could possibly work as long as it has something to do with being active and getting a patient moving and addressing their specific concerns and their expectations in an evidence-based way. So that's what we're going to talk about a little bit further down in the presentation. So if we see right here, again, another Cochrane review, motor control exercise is probably more effective than a minimal intervention for reducing pain, but probably does not have an important effect on disability in patients with chronic low back pain. There's no clinically important difference between motor control exercise and other form of exercises or manual therapy for acute and chronic low back pain. So the previous Cochrane review was all about acute back pain. This one included chronic low back pain as well. So we can see 32 trials, 2,628 patients. These studies were at a low risk for bias, and we again see that motor control exercise probably more effective than nothing, but probably not more effective than other forms of exercise. So if you guys have ever talked to Ben Cormack, you know that he says Pilates. So what about Pilates? Again, Yamamoto, 2015, Pilates versus other forms of exercise. Again, a Cochrane review. We didn't find any high quality evidence. There's low quality evidence that Pilates is more effective than doing nothing when Pilates is compared to other forms of exercise. Hey, maybe it works a little bit. There's some effectiveness for the evidence of Pilates, but it doesn't seem to be more effective than other forms of exercise. And I underline the last sentence because I think this is the most important sentence in the entire systematic review. The decision to use Pilates for low back pain may be based on the patient's or care provider's preferences and the cost associated with the usage of Pilates. So if you have a patient who has chronic low back pain and they absolutely love Pilates, they love the idea of Pilates, they enjoy doing it, it's going to be the thing that gets them out of bed and actually gets them to do some exercise, we shouldn't tell them that they should not do Pilates and forego that for other forms of exercise that we think are more specific or likely to provide them more specific benefits, such as core stabilization or motor control exercise. If we can utilize their own preferences to help them out, that's the road that we should possibly take, because there's a way higher likelihood that they'll actually be engaged in the program that we help them develop. So what about the mustache? What about McGill? Some good research conducted here comparing McGill's big three to general conventional physiotherapy, and they looked at pain, functional disability, and active back range of motion in patients with chronic non-specific low back pain. This was just published a couple of months ago. And what they did was use, so if you're familiar with McGill's big three, you know that it's the specific curl up that he advocates for, the bird dog, and the side plank, if I'm not mistaken. So these were the exercises that they used, programmed how Stu McGill would encourage them to be programmed, and they were compared to conventional physiotherapy, which was just some basic trunk-focused exercises and range of motion exercises, pulling both knees up to your chest, pulling single knee up to your chest, doing some pelvic tilts, and doing some bridges, I believe is what they compared it to. And the results showed that there was no significant difference between doing the highly specific McGill Big Three exercises and doing some single knee to chest, some double knee to chest, some pelvic tilts, and some bridges. So it shocks me that the McGill Big Three was not better than these other exercises, because I would, in my biased way, look at some of these other exercises that were used in the traditional or conventional physiotherapy and say, well, this isn't necessarily just the best exercise. They didn't do this. They didn't do that. They weren't challenging these people's biases. They weren't pushing them really hard to get stronger, to do X, Y, and Z. But that's my own bias. And the research clearly shows that it seems that there is something other than the specific effect of the exercise itself on muscle tissue or on the neuromotor system that seems to be that which decreases patients' pain and disability. What that thing is, we can make a lot of theories, we can postulate a lot of things, but we simply just don't know at this point. If we knew, we could isolate down to the components of treatment that would actually be the most effective. And you guys have all seen the data on chronic low back pain and how it's getting to be a bigger and bigger issue every year. There's more and more people that have chronic pain. There's more and more money spent on chronic back pain, and it's the #1 musculoskeletal expense nationwide, probably worldwide. And I don't know if the data reflects that, but if it is nationwide in the United States, I would expect that to extrapolate out to some degree into most of the other developed nations as well. So what about subgrouping? So if you guys are familiar with Shirley Sahrmann, there's a big following that believes that subgrouping of patients into movement systems impairments might actually be the best way to go about it. And they would claim that we haven't had good research yet to show the effectiveness of a lot of exercise because patients haven't been subgrouped appropriately. But if we look here at this study where they used this subgrouping method based on the movement system impairments model, then there was, again, no significant clinical difference between all of the outcomes. And what I did find was interesting, if you read, is patients in both groups reported significantly less disability on the Roland-Morin Disability Questionnaire at 12 months. However, the mean change in the Roland Disability Questionnaire between baseline and 12 months measurement showed a statistically significant superior improvement for the specific motor control exercise group. They had a change of 1.9 points more. But if you actually look at a clinically meaningful change for the Roland-Morris Disability Questionnaire, it's 3. So these people did have a statistically significant change of negative, or of 1.9 greater than the control group or the general exercise group, but it did not even come close to reaching clinical meaningful change. So I think that that's really important when we read a lot of this research, or read a lot of these abstracts, and quickly gloss through some conclusions and discussions. We don't automatically take what the authors say without reflecting on if it's clinically meaningful or if they're not bending the data to benefit the point that they're trying to prove. So what was even more interesting about this study is that there was confounders, because the therapist spent a significant amount more time with the patients in the specific motor control exercise group, because they had to teach the patients with hands-on manual cueing and verbal cueing how to do these very specific movements. So if you guys are familiar with, for instance, like the Sahrmann 6-step and the Sahrmann 10-step exercises, they're really specific exercises that have to do with sequential movements of the pelvis and the hips and the legs. And a lot of times patients need a lot of feedback to do these exercises appropriately. And when you actually read this paper, you see that the therapist spent quite a significant amount of time more with the motor control group than they did with the general exercise group, which is a huge confounder for what we know about the impact of therapeutic alliance and contextual effects of a patient thinking that they're getting more treatment or thinking that they're getting a higher quality treatment automatically confounds the outcomes of a study. So I wanted to go into one more example of when abstracts lead you astray. I got a kick out of reading this study. Chang in 2015 conducted a systematic review for core strength training for patients with chronic low back pain. And this systematic review used previous studies to explore the effectiveness of various core strengthening exercises, and their results and conclusions say that all core strengthening strategies examined in this study assist in the alleviation of chronic low back pain. However, we recommend focusing on training the deep trunk muscles to alleviate chronic low back pain. Yet, here is a direct quote from their results section. According to the visual analog scale and the McGill pain questionnaire results of the studies, pain was reduced following core strengthening exercises, although not statistically significant. No statistically significant differences were observed from control groups or general exercise groups when you compared them to core strengthening. So their own results conflict with what they were saying. And then you ask, what did the control groups do? If they got just as good as the core stability exercises, the 4 studies in which they referenced that actually had a general strengthening program were sit-ups, straight leg raises, and push-ups. So just very general random exercises. Work on your pecs, lift up your legs, and do some curl-ups. So it was really interesting that this study in the conclusions pretty blatantly states that they believe that deep core strengthening exercises should be done, yet there was no difference statistically at all in pain and disability, and this is what the control groups did. So if we move on and actually look at what we see in patients with back pain, I referenced some studies here of the general observations that we make in people with back pain. Hodges 2009, we see increased stiffness. Lameth 2002, we see a decreased variability in walking. So we see that people seem to become stiffer and they seem to become less variable. Fala 2014, increased muscle activity with decreased variability with lifting. So again, we see, hey, muscles seem to be overactive. We seem to see less variability with walking and lifting. We go to Sang, if that's how you pronounce that appropriately, 2017. And now we see less variability with bending. So we've seen less variability with walking, less variability with lifting, and less variability with bending. Now, Hernandez 2017, less lumbar movement and decreased variability and increased stiffness yet again. So to quote, I don't know how to say his first name, Carton Vibe Fursum. Somebody's going to kill me for that. I apologize. If people in pain walk like a walking plank, don't put them into a plank. If pain and muscle guarding serve in protective roles of the body, should we be giving everybody core stability exercises? If we're seeing increased stiffness around the trunk, less movement around the trunk, less variability in exercise and movement during everyday life, should we be making people stay stiff? Should we be facilitating the idea that people are stiff or are unstable and that they need to stiffen up and that they need to be very rigid in the way that they lift up objects or be very rigid in the way that they move throughout their day? So I would say no, because people with chronic back pain appear to move differently. This is characterized, they have less variability, they have less movement, and they're more likely, these things that we're seeing are more likely an effect rather than a cause. So we're probably seeing these changes in muscle activities and this decrease in stiffness and this decrease in endurance and this limited variability in movement as a protective response or an effect of the persistent back pain rather than a cause of the back pain. So we probably put the evidence cart way before the horse, right? We saw some muscle activity changes and automatically assumed with post-hoc reasoning that these muscle changes must be the cause of back pain rather than saying, ooh, these muscle changes, they might be a result of back pain. So what should we do for people with back pain instead of core stability exercises? We still exercise. You guys saw all of the research, systematic reviews, randomized control trials that showed that All of these exercises worked. Core stability exercises worked. Motor control exercises worked. Pilates worked. Yoga works. Lift weights if you want to. Walk, run. All of the different modes of exercise work for different people at different times. So what we need to do is try to find out what mode of exercise seems to be the most appropriate for that patient in front of us based on their expectations and their beliefs. Sometimes clinician bias can play a role in this as well. If you're really fired up and gung-ho about a specific intervention, you will tend to have better results with that intervention because the contextual effects that go along with you actually using that intervention with people. So the ultimate thing that we must do is reframe what we say to patients. So if you change nothing, nothing will change. If we keep doing all of the same exercises, if we keep doing all of the same manual therapies without changing the narrative, we're probably going to be stuck in the same rut of having limited success that we've seen over the last 20, 25, 30 years. So you guys already know this study because you read it week one, the enduring impact of what clinicians say to their patients. We have to be absolutely mindful and conscious of what we're saying to our patients, how we're saying it, when we're saying it. We can't slip into accidentally throwing in some nocebo and inducing fear avoidance behaviors and maladaptive beliefs, because that's going to facilitate even greater fear in the patients. It's going to impact their beliefs that lead them down the road of being more stiff, being more variable, being more hypervigilant and protective, which is actually going to feed into and likely facilitate all of those things that we're seeing in these different research studies. And then, of course, if we move on, this is one of the big quotes from the enduring impact of what clinicians say to their patients. And there's been a lot of discussion over whether this quote should be used or not. But I've told people when I've used this quote before in presentations, to this day, I've had 9 women personally message me after posting this quote and let me know that they have either decided to have a hysterectomy, decided to not have children, or in fact, one has actually reached out to me and let me know that she also had an abortion because she was too scared of the back pain that she was going to have and didn't feel like her body could actually withstand carrying an extra 6, 7, 8, or 9 pounds, 10 pounds in front of her spine. So this might seem like a bit of an outlandish comment to some people, but it's actually not that outrageous, because there are quite a lot of people who have experienced the same or similar things, having negative thoughts implanted into their heads by their interactions with clinicians or the rhetorics that society is currently using to explain things like back pain. And of course, you guys also had this study first week, easy to harm, hard to heal. Negative assumptions about the back made by those people with low back pain may affect information processing during an episode of pain. This may result in attentional bias towards information indicating the spine is vulnerable and that it's serious to injury, or and that an injury is serious, or that the outcome will be poor. So if we're telling people, hey, your spine is unstable, your back is unstable, your core is weak, it would be very easy for a patient to misconstrue what we're saying and develop the idea that their spine is very weak, it could fall apart. The idea of instability typically conveys a picture in somebody's head that looks like a stack of Jenga blocks, or it looks like a wall of bricks that's about to fall over. Things that are unstable don't have a lot of strength. They can't hold up to activity. They can't hold up to stress, when we know that stress and activity is exactly what the body needs to get stronger. So what are our take-home messages from this presentation? There are no magic treatments for back pain that work for everybody, unfortunately. There's lots of different types of exercise that have a positive effect on low back pain. And I think this should be a really positive thing. This should be one of the weapons that we have, is the fact that we don't cling too tightly to any one specific type of exercise. If a patient tells you, I absolutely need to get my trunk or core stronger to make my back pain go away, then it's perfectly okay to use some trunk strengthening exercises with them while you slowly change their ideas and their beliefs over the course of time, the time that you're treating them. None of the exercises seem to be superior to any of the other exercises based on all of the research. So we have multiple modes that we can use. We need to focus on the human being and not just the back. We need to focus on the person that is actually living with back pain rather than the back that is inside the person that we tell them is causing their pain. Exercise that people enjoy and is easy for them to do will probably get done, and that will probably lead to a positive effect. So if somebody loves yoga, find a way to facilitate them doing yoga in their rehab program. If somebody loves Pilates, find a way to utilize Pilates. If somebody loves going to the gym and doing deadlifts, you better work on a progressive deadlifting program to help with their back pain. It's finding those things that are meaningful to the patient and gradually exposing them to those activities in a way that doesn't cause them too much of an issue and actually violates their expectations of what's going to happen, all the time explaining what we are currently coming to know about pain neuroscience and neurobiology and all of that sort of stuff around pain education. Consider a rehab program that combines different exercise variables. You could try high load, you could try low load, strength, maybe work on power, work on some control, work on endurance, flexibility, work on being fluid, work on flowing like water. I quote Bruce Lee in clinic all the time, as you must be water. When water is poured in the glass, you become the glass. You know, everybody's heard Bruce Lee say that quote, and it's incredibly true. Confident, pain-free movement is extremely fluid. It flows. It doesn't look stiff. It doesn't look restricted. And most of all, try to have fun. Try to make exercise fun. So to steal a little bit from Ben Cormack, we have a tendency to make exercise very unfun and very plain Jane and very over-medicalized. So if we can bring some fun back into the clinic, we might have patients that are a lot more engaged and change the way that they feel and believe about moving. So positive effects from exercise for low back pain may not be directly attributable to anything like strength or mobility or endurance. It might be attributed to something much more complex within perceptions in the central nervous system. Structural factors such as lumbar lordosis, pelvic tilt, leg length discrepancies, and muscle length are not likely to be associated with pain based on any of the research that we've done to date. Decreasing stiffness and promoting freedom and variability of movement should be our goal in rehab, especially with those people that are displaying fear of movement. People who feel that they need to protect their backs usually have worse outcomes. If you feel like you need to protect your back and you have maladaptive beliefs, that usually leads to inactivity and passive coping strategies, which are well documented in the literature to decrease the outcomes that we have. So those are the take-home messages, and that's where we're going to close off for that. And I've attached all the resources that are referenced in the study here, or in the presentation here at the end.